Hello there, my name is Mark Wardley. I'm a consultant neurologist really, but I'm going to be talking about diagnosis, management and decision making and the use of data in supporting the health of a nation. So our default must be that we're always orientated towards action. So that means making decisions. So if I'm seeing you in my clinic and I need to make a diagnosis and a management plan together, then we need to ask ourselves, what are we going to do? And it's all about information at the right time. All my maps are wrong, but I hope they might be useful. I'm going to try to take us through what I think we need, what we have, and then I'll finish with what we need again. So I'm going to switch to Visual Studio. So this is about clinical decision making. And most of what we have is unintentionally designed, and it's evolved organically, and it's not fit for purpose. So we start with a situation of uncertainty, and everything that we do is surely needing to reduce the uncertainty around a specific decision. Are you going to have that knee replacement? What are the trade-offs here? What are the pros? What are the cons? Are we going to use this new treatment with this patient with COVID-19? How do we identify the patient with COVID-19 who's going to need higher level care? So we start with professional and patient, and we're going to have to make a decision. And that somewhat is based on a diagnosis of the problem, which may be possible, probable, or definite. So already we're starting to think this is iterative. We're going to need feedback loops because we may need to make a speculative diagnosis, confirm and adapt as we go. We do not have a linear process. It is iterative, and that is the clinical method. So what do we need for clinical decision making? So I'll just release these. So we need situational awareness, and here we need to understand the prior probabilities. So that uses Bayesian inference. So if somebody's got a fever when we're in Africa, it's likely to be a different diagnosis if you have a fever and you're in the United Kingdom. So your prior probabilities are really important. We also work on pattern matching. And the standard diagnostic method is all about pattern matching, and that's what we teach at medical school, and that's well developed, well evolved. We teach it, we expect it to be done. We look at symptoms, what the patient describes, signs, the things that we can find on examination. We use investigations, we use our clinical skills, and that's all on the basis of training, and training that occurs over many years. But we have to learn through doing. So we need to look at feedback, and so there's this iterative loop here where we're continuously learning, and we have that kind of feedback for when we're looking at an individual patient. But also, shouldn't we have that kind of feedback when we're looking at cohorts of people, somebody attending a service, somebody coming to that hospital, or somebody as defined by their characteristics, so their ethnicity, their age, their diagnosis, the treatments that they've been on. And also, shouldn't we be doing this for advancing science? So it's about clinical research as well. And we falsely separate these at our peril. So what do we need for our feedback loop? So we've got feedback here. And so if I just expose the next set. So for continuous learning, we need continuity, and that is often neglected in trying to reduce healthcare to something that's really reductionist. We need to focus on outcomes, which we do not do. So how do we assess what we're doing unless we're measuring in a systematic fashion outcomes? And if we need continuity and we want to focus on outcomes, we need to share data, and that means making it systematic, and we do not do that at the moment, apart from in kind of areas of innovative practice like joint registries. Then we've got to make sense of that data. So if we're going to measure outcomes, well, it's no good just assuming that we can interpret those results. How do we need to make sense of those outcomes in data? So it comes down to meaningful data. So how can we capture meaningful data? So it comes down to data standards. So we need to be collecting the same kind of data. We need semantic interoperability, and we need to have widespread implementation, which does not exist at the moment. So these things are often proprietary, and then at the moment in most healthcare systems we have custom-built data centres in each place, although that is changing. So at the moment, this is what we're trying to do, is move to a focus on outcomes, in making sense of meaningful data, and on building open implementations, open source implementations of data standards, and making data standards and data interoperability a commodity, ubiquitous across our ecosystem, and moving to generic computing services such as our cloud providers. So these are the areas that we need to focus on. How do we build and focus our efforts to build what essentially is a learning health system? So that's what we need to do, is focus on meaningful outcomes. It's about value. Is it worth doing a tonsillectomy on that child, or is it better that that child is managed conservatively? How do we share data that's safe, distributed at scale with consent and control? How do we make sense of data? What tools do we need to make sense of data in context? For example, we've got work that shows how a patient with multiple sclerosis progresses over time, but that only makes sense if you compare it to the rest of the cohort. So we need tools and data in order to support our decision making. Much of this should not be custom built. Most of it should be shifted right over, so it should be for the commons. Why on earth are we still running our own data stores, pipelines and compute infrastructure in our health organisations? That is not a first-class problem for those organisations. We should be buying it. These are commodity services. And it's interesting when you look at what I need as a clinician and what a patient needs as a clinician is not that different to what algorithms we need. So if we want a new algorithm, that might be assessing your stroke risk, decide whether you need to go on a specific treatment like anticoagulation, or perhaps it's a machine learning algorithm to interpret chest x-rays. Do you think at the moment we've industrialised this process? Do you think we can just acquire that capability? Or are we still breaking new ground every time we want to do this? Well, it won't surprise you to learn that we're breaking new ground. So we have algorithms. So we want to use algorithms in our clinical practice. So what do we need for that? So we can use mapping to help us with this. So here we have algorithms that are predicated upon clinically meaningful data. We've got some patterns emerging here. Algorithms are predicated upon trust in those systems. And also, if we're going to do some machine learning, we're going to need to have develop expertise and have training in these models, and we are just at the beginning of that journey. How do we inculcate trust in our systems? Well, we need to embed quality improvement in everything that we do, and that means monitoring continuously the results and evaluating the results, not 2 years down the line, but instantly as a snapshot, and that's built upon data flow and store. And we need to inculcate trust by engaging, so that means engaging with our population, but also engaging with professionals. And how do we build clinically meaningful data? Again, clinically meaningful data needs semantic interoperability, open standards, and that means us collaborating in a way that we do not do at the moment across nations' borders. And semantic interoperability and providing clinical meaningful data needs data sharing, engagement with our public, needs to give them meaningful consent and control over how they share data. And finally, implementation of open standards, so how we mark up and record and store and process data that's clinically meaningful needs to have open implementations. So we need to evolve those into commodities. So we need to make these kinds of tools, the meaningful consent and control of data, and the kind of core compute infrastructure supplying software and libraries. For all of this work, you need to be commodity. We need to be building at a higher level of abstraction here in order to deliver what we need. And so that's what we've got in this diagram here, which talks. This shows the change over time. So building trust based on transparency, and separating the data from the software that operates upon it through the use of readily available open source tools and libraries. They're the aspects that we need to be focusing on if we're going to deliver this for patients and citizens. So it's all about fast feedback. How do we do it? Safely distributed at scale with consent and control. How do we build systems that inculcate trust? We need a foundation of ongoing monitoring. And our implementation, use of standards should not be a differentiator in the marketplace. You don't choose your browser based on its implementation of HTTP. You just use your browser to do cleverer things. We need to be getting our suppliers, the commercial sector, to be thinking much higher up the value chain and delivering value. They can't be differentiating on the basis of this low-level stuff. So really, machines don't actually need much different to me. So what actually do we have? So I've got a map that shows the current state. So here's profession and patient. We're bound to our organisations at the moment, and that's a problem that we'll talk about in a minute. And here we've bought an off-the-shelf electronic health record, so that's firmly in the product category. We've built a patient portal which is dependent on that electronic health record. In fact, most of the time that patient portal will be from the same supplier as the EHR. There's a few exceptions to that. So an organisation now decides, once they've built that EPR, that they want to look at their data, and so they need some population analytics. And so they go to their vendor and they buy that, and it's from the same vendor. And that gives them access to all their data. So they have to buy that separately. And then the organisation wants to share data in a regional aspect, so they buy the product's health information exchange product. So that's fine, so now they can exchange data with other hospitals, other organisations within that region. But the problem is this EHR. Well, it's not just a greenfield thing. They've got a ton of in-house developers. And so they need to solve things that are local. The electronic health record actually doesn't really solve their problems, which is an interesting observation. So they buy an API product because you've got to buy that. So the API is dependent on the EHR, and that's interesting because actually probably it should be the other way around. But this is how the market is at the moment generally. So that's fine. We've got our in-house developers using the API to develop extra things on the EHR that was not quite right for them. And then we've also got to solve research, but that's completely separate. So these are all new, they're all different. There's normally a research registry for, say, a joint or orthopaedic surgery or cardiac surgery. And good luck trying to reproduce that research because it's all novel, it's all new, it's not systematized at all, and it's all completely separate to the EHR. So that's not great. So let's see if I can do this. And of course, actually, when we first install the EHR, we we did have a load of other legacy systems as well, which we've got to integrate, and that integration, so the EHI is dependent on that integration actually. So crumbs, we've got to like build and links to all of our existing systems and integrate those. Plus also it's not right for us at all at the moment, so we've got to customize it to our own local workflow and processes. And so actually most places that buy an electronic health record kind of end up hiring more developers to do that kind of integration and customization work. So some of our capabilities that we need are predicated upon data standards. So for example, if we're going to be doing API work, if we're going to be customizing, we need to be collaborating. We need data standards and data standards bodies to tell us how to interoperate with these data. So through our health information exchange, for example. And similarly, all of these need some compute and data kind of back ends. And in general, modern EPRs, they'll build on cloud services, but all our legacy is still all the way over here. So, what are we going to do when we look at this? Well, it tells us a few different things, really. One is this API product cannot still be a product. This needs to be a commodity, and we need to look at that. We need to make data standards and evolve data standards to be something that's kind of ubiquitous. We need to get our legacy data out. We need to stop building our own data centers and move over to the cloud. But there's also some other issues here with this separation of research and clinical work and analytics, which I think are really interesting. So that's where we've left it. So what about the big tech vendors? So I give them a D-, right? They have principally failed in health, actually, or haven't really started to get going in health. They've pretty much focused on compute and data infrastructure. Interestingly, Apple doesn't do that, but they have built a mobile phone app, Apple Health, which gives them access to, gives us what is essentially a patient portal. The others don't really do that very much. They're mainly focused on cloud. And that is disappointing, actually, because there's a lot that they could bring to the table. And our big question for an EHR, when you look at it carefully, is do you buy all of that from a single vendor, or do you try and build a best of breed through buying bits and pieces and then trying to link them all together? Either way, it becomes fossilized and difficult to change because you've kind of glued it all together. And the danger if you buy lots of different things is you've just got a combinatorial explosion. So you've got to kind of make them all interoperate unless you build some kind of platform, which is where I'm going with all of this. And then the final observation on this is that why on earth are these things so separate? So we completely think of data analysis and analytics as separate to direct care, when in fact actually direct care would benefit from embedding analysis in there, show us the data for your individual patient in the context of everybody is a very powerful approach. And why on earth have we got research systems over there? Surely these things are simply different facets of the same thing. You've even got separate languages. We use R for analytics and we use different computer languages and data stores for our electronic health records. You have to step back and challenge one's assumptions, and mapping has helped you do that. So if you just think about an electronic health record, what do we actually need? Well, there are two broad options. You can kind of buy a monolith. So you kind of buy it from, say, Epic, which is a monolith, or you buy it from Cerner, and actually that's not a monolith really, but they've done the work to glue it all together so it feels like a monolith. Or you buy all these bits and pieces. But whatever you're doing, what do you need to do to deliver on that? Well, any EHR is generally fixed on billing. And billing needs clinical data. Billing needs identity services for staff, who did what, and patients, who you're doing stuff to. And billing also needs to track orders so that they can charge you properly. The EHR does need workflow, but that doesn't feel like it's very well advanced. It's not a mature thing. Workflow is often neglected, actually, and that's to our detriment. Any clinical service needs things like clinical calculators, which are often proprietary and built into the EPR. Data sharing is novel and new. It's kind of a paid-for thing. You have to link it yourself or extract the data or do it. It's all in the novel side of things to integrate, which is wrong. We're already seeing challenges here. Things like reference data, audit logging, geographic data, knowledge bases, terminology, that should all be commodity. A lot of the implementation of open standards that underpin things like results, documents, laboratory data and radiology should be all a commodity. They should be open source. We should not be differentiating. This should be the basics. These are the foundational building blocks. And yet actually we don't have that. We're still buying these things here as individual products. So this is a typical monolithic EPR. They own all of this bit in the middle. They might delegate for staff identity to a Windows domain controller or something like that. And then you might use the EPR vendor's own laboratory and radiology system. You might buy those and stick them in because of the standards at play. That does kind of work. The other option is you do a best of breed approach. So you have a clinical system and then you glue it to staff identity, document services, different laboratory services and radiology. And there's not really one best way of doing it. But again, integration is novel and difficult and custom. So I don't think actually thinking about the needs of the EPR is good for the health of the nation or good for my health. I think we need to start with user needs. The problem is that the organisations in which we work are not the user, but in general they hold the purse strings, and that is a problem. So let's go to what we need from an EPR. So that's that, and then true needs. So this is the final map actually. So I think of users as researchers or managers or policymakers or clinicians or patients, and I'm going to try and draw out some of the parallels here and some of the questions you might be asking. We need to make a decision about, how do we address inequality in our population, or how do we judge that that treatment is safe? How do we improve our service and improve our outcomes? Should we use this high-risk treatment in this individual patient or in this group of patients? When should we see that patient? Can that patient be sent home? What is the treatment for this patient? And I guess you could divide the needs of a decision into three. Evidence. You need to have communication around that decision making, and you need to take action on that decision as well. So let's focus on decisions. So the first thing is about the evidence, and we need to support our decision making with evidence. I think we do not have sophisticated tools for decision support at the moment. That is an area ripe for innovation. This is all predicated upon meaningful data and a focus on outcomes, which still at the moment is not ubiquitous in our clinical systems. We're very much transactional. We record stuff about counting, numbers of encounters, but I have no idea how those patients are doing. Our outcomes and meaningful data are surely based on distributed data. We can't be organisation-centric here. We need to be sharing data, and that requires trust. That requires openness, transparency. It requires open standards. It requires clinical data that's meaningful. If we're going to take action, we need systems that manage our workflow. And that means building systems for feeding back into our decision support and evidence. So we take action, we have process management. We have no tools for orchestrating complex pathways of care if they span more than one organisation. It's manual re-entry. We're reinventing the wheel and every time, when in fact actually we should be giving tools to the users to manage complex pathway building using low code or no code declarative environments, setting up rules predicated, built upon clinical data, and generating processes and workflow that work for patients, measure how it works, and continually improve our systems. We do not have this. We see a problem here. If we're going to be sharing data and moving it around, how on earth do we distribute that data in a safe way? So we need a ton of novel work here. We need to inculcate trust based on a finely grained authentication system. So we need clinical data that's kind of comes with a wrap of authentication, what that data can be used for. If you're going to distribute data, we need systems to locate that data across our enterprises. We need mechanisms to distribute communication between entities. That may be researchers, clinicians, patients, organisations. And we need to give tools and have tools that support distributed control. So what that means is placing the tools in the hands of professionals and patients to control their own data. And that requires us to be innovative here. We need to be looking really carefully at these modern, new, just on the cusp technologies, secure enclaves, differential privacy mechanisms, and homomorphic encryption. So how can we spread data, make use of data, but do it in a really safe way with an envelope of consent and control from the patient? And then all of that should be based on our core foundational services, which should be a commodity built on open standards, simple and complex clinical data that's meaningful, combined with reference data to give context, and built on commodity compute providers. So I think this map's really helpful. Up at the top left, we've got lightweight, user-centered, declarative applications that are composing complex tools. They're predicated upon workflow and process. They allow users in the health system to build processes, build workflows to systematize healthcare. If you're coming in for an operation, it needs to be like a flow of work, or carefully orchestrated. I think if we're going to really place outcomes and trust and distributed data at the heart of the health of the nation, then we need these novel, ambitious, and enabling technologies which are going to disrupt the current market for electronic health records. Because if this work is distributed, we've broken the lock of organisations, and we're focusing back on our clinicians and patients together making decisions that are right for them. In the middle, you've got some of the culture and principles that I think we need to work on: transparency, trust, standards, collaboration, outcomes, and openness. And then we need to be building on these core boring infrastructure bits. These are the dependable commodities, knowledge bases, reference data. Arguably clinical data should be in here with built upon open and commodity data stores, data pipelines, funneling this data, and open compute. So I think that tells us what we need to do. We need clinically meaningful data. We need data sharing. You can look at the privacy enhancing technologies. We need to build out trust, and we need to move implementation of open standards to open source. Open source is a strategic bet. We need to get modern technology companies to treat cloud as more than simply moving a data center to somebody else's kit. Cloud potentially opens up health and care data. If we can do it correctly, this is huge disruption for the existing market. We've got to push suppliers. We can't be differentiating at these low levels in the weeds of whether it's a cloud running on cloud or not. That's ridiculous. We need to be focusing on value and outcomes for patients. So thank you.